So welcome to day 2 of our web series. I'm Natasha Smith, the Managing Director of the Women's Health and Wellbeing Initiative. Today we are joined by Cassandra and Ori, and they're going to introduce themselves because I feel like everybody is a better introducer of themselves than the person that's hosting. So they'll introduce themselves. So today we're looking at decision making and exploring kind of the areas around mental health. I think that a lot of the time we always think about just the kind of like birth physiological side or the kind of biological side of inductions and births, but there's also a bit of a wider field that we need to consider when it comes to birth, such as the impact of mental health on birth or mental health, but also the way in which people make decisions. And this is going to be a really, really interesting day today. So take note, get relaxed, sit back and enjoy the session. If you've got any questions, pop them in the Q&A or the chat. I'll make sure I'll be checking them. We also just need you to know that we'll be talking about potentially loss today, or it might be mentioned. Also trauma, various types of trauma, violence or sexual trauma might be mentioned today. So if you feel that it may trigger you or if it affects you, then please speak to somebody who's a mental health specialist or your GP. If you're affected, you can get in touch with me if there's anything that affects you today, and I will signpost you to the appropriate channels. So just a heads up for those that might be triggered by any of those topics. So Cassandra, would you like to go first?
Sure, thank you so much, Natasha. Can you hear me? Is everything okay? Great. Hi, everyone. My name is Dr. Cassandra Ewell. I'm a medical anthropologist. I'm based at the Center for Maternal and Child Health Research at City University of London. My background is in medical anthropology, and my research focuses mainly on maternal health and maternity services in the UK. I've done research on parent-infant sleep, place of birth, midwifery-led care, and I'm currently part of a team that's undertaking research on induction of labor. So yes, thank you so much for having me.
Thank you, Cassandra. And Ori?
Hi everyone, I'm Dr. Orinayo Onabanjo, so I'm a counselling psychologist. So I work in the NHS and privately as well, but I have a particular interest in working with mums during pregnancy and the postnatal period, and parents to be really. So yeah, really excited to be here and talk more from a mental health lens.
Thank you. So if you keep yourself unmuted, because we're going to have a conversation and you can just kind of chip in and be smoother. Cassandra, do you want to kind of hit us off around the area of decision making and kind of share with us like a bit of your research and what you've kind of discovered?
Mm-hmm. Sure. So my PhD research focused on, so not specifically induction of labor, but women's and parents' decision-making experiences around place of birth. So that's sort of the direction how I became really involved with, all of these things and discussions and pieces and bits and, issues around decision-making and informed choice. I sort of approach this from an anthropological perspective when I'm thinking about informed choice on decision making. And so I guess when we're talking about it, within the context of maternity care, we have a very strong policy agenda within the UK that puts women and people central to the decision-making process. This is supposed to be person-centered care. It's supposed to be personalized care too as well. And well, I've just seen a message that says the volume is low. I hope everyone can hear me.
Is that for everybody, the volume? Could you just give me a kind of yes or thumbs up if the volume is too low? Because I can hear really, really clearly.
Okay. Okay. Just wanted to make sure. Okay, great.
Okay.
Okay, great.
Everyone else.
Yeah. So yeah, with the current maternal health policy in the United Kingdom, it's really placed, informed choice and personalized care really at the center of the policy agenda. So it's really important, when we're looking at, when we have it so central to our policy making, we need to make sure that, how is it, we ask all these questions about how is it happening, if it's happening, and if everyone's able to make these choices about their care. I can go on, but I know it's a conversation. So yeah, stop me at any time. So this is sort of the approach that I sort of take it at, and this is where my interest comes in. So because that is my own, I sort of look at this anthropologically. I've been really in my current work with induction of labor, also really focusing on that aspect of it, the informed choice aspect of it, the decision-making aspect of it. Because we know from research studies, and I'm going to be talking predominantly about qualitative research studies and qualitative research, that women's experiences when they're having an induction of labor, not only do they find the experience of induction of labor quite challenging, but they also have reported gaps in their information and the information that's given in their information needs. And so women often feel that the decision about induction of labor is made for them and not with them.
Sorry, there's a bit of background noise.
Okay.
So, Cassandra, I'm really interested. So what are the types of things that you kind of discovered that really shape decision making? Because a lot of the time, I've done some work in choice and personalization on the MTP, maternity transformation program, for those that don't know. And a lot of the focus is like human rights in childbirth, looking at evidence-based and presenting evidence to parents, weighing up the benefits and the risk of interventions or certain pathways. But is there anything else that's kind of a bit more wider and things that we don't typically think about that, like you found from your research?
Sure. I guess, I think it's really good to sort of, I think always ask when we're sort of, because I took, I took a, when I was doing my research, I did a systematic review, which is basically bringing together a load of research studies and reanalyzing them essentially. So we took 37 qualitative research studies around decision-making, parents' decision-making of their pregnancy and birth care, and sort of analyzed what was going on within those studies altogether as a whole. And they sort of came up with a different conceptualization of decision-making. But I think what, is good to go back is to, sort of think about, first, if you're going to unpack it, what is, as far as the definition, what is an informed choice or informed decision, depending on, how you want to look at it. There are a lot of definitions out there, but usually, people see it as an informed decision is one where it's a reasoned choice made by a reasonable individual using relevant information about the advantages and disadvantages of all the possible courses of action in accord with an individual's beliefs. So I'm reading off the definition, so I've got some notes. I think the two main elements of this are that it's a decision that's made after reviewing all of the relevant information, and that it's based on the individual's beliefs and values. And this kind of makes up the sort of foundation of that concept of shared decision-making, which we often hear quite a lot around. It is something that is also core to, this policy and to the way that decision-making is approached within care. These decisions made in partnership with healthcare professionals between, the woman and the pregnant person and the healthcare professional. And so I think for my work, where I come into it, because I'm, doing this with an anthropologist hat on, taking quite a critical approach to it, oftentimes, I really think that this is, a concept that is, based on an assumption that there is a reasonable decider going through a rational process. And for me, I always sort of step back and question, well, who is a reasonable individual? What's a rational process? Where's this coming from? And so when doing that, kind of, looked at the fact that the way that informed choice, at least we found from our perspective when we were doing this review, was one that didn't necessarily fit what was going on in real life. It's quite an idealized process. And so, when we started to, think about a new way of approaching decision-making, that was sort of where we started from. I hope that answers the question.
I've got a bit of a question about what you've just said. So it sounded like a process that was like, we're going to start here and then we're going to end up here.
Yeah.
Is that, like when I think about my experience, like I don't think that way. I don't think, okay, I'm going to start here, and then when all of these things are told to me, I'll finally end up here and that's it. Like my decision is not like this kind of straight and narrow path. It's like, okay, I'm going to go off here a little bit, I'm going to go off there a little bit.
Yeah.
I need to go back and then come back on myself. So
yeah.
Did you kind of like find anything like around that kind of the way in which people arrive at decisions? Because last night when we spoke about it, we was talking about like when people need to make this decision, usually with inductions, not all the time. Sometimes people have, weeks to prepare, or they know maybe from the beginning. But there's a group of people that might have to make a decision very quickly. And so how do we really support decision making? There's probably more than one question there anyway. So going back to the first one, what does decision making really look like?
I think you really hit it. It's from my perspective, from my work, I don't see it as a straight line. I don't see it as, from point A to point B. And I think, sometimes we are really concerned with the end point of this, that point B, when that decision is made, when that choice is made, and whether it's informed or not. So when we were looking at, all of this research around, people's experiences of making decisions about their pregnancy and birth care, I found that, decision-making and choice is really something that's centered, in the body and like comes from the person and their body. It takes that into account very, very much. And so we also found, sort of that's where we sort of started with, and that's sort of the core, that is the center, because obviously, the person, the individual is the center, when we're talking about it, we're taking this human rights approach, we're looking at the policy, a rhetoric and agenda. But there's also all these other things that are going on around it. So we also found some of the main themes that came out of this were, the decision-making process is really, it involves a lot of uncertainty, which kind of encompasses these considerations of risk. It also involves this bodily autonomy and integrity is how I framed it, which is basically sort of focused on control. We always hear a lot about, people really wanting to be in control of, their care and what's happening to them. But sort of we kind of wanted to expand this out and sort of, bring it outwards basically. And then also, performing good motherhoods or good parenthood. And, making a decision, sometimes can involve, how am I going to be seen as like the best parent? But at the same time, we also recognize that this is a process and this is active, decision-making is very active. And so we sort of thought about these, these interlinking actions, and that included information gathering, of course, aligning with a birth philosophy, and balancing all these aspects of choice, as you were talking before, going back and forth, between the different options. And then to make it more complex, because it is a very complex process. And that was one of the main arguments, was like, this is a really complex thing. It's really dynamic. It's got all these aspects to it. It's not just, point A to point B. It's like, it's not a straight line. It's like a really a Venn diagram of sort of all sorts of things. But we also thought, that we noticed that this framework is sort of multi-dimensional in a way. It's like it considers time. When people make decisions, as you were saying, like sometimes you go backwards, you're not just thinking about the future, you're not just thinking about the present, you're also taking into account the past. And that can be like your personal past, your familial past, and for sometimes for people also the historic past too as well, when they're making all these considerations. And so that's what we really wanted to show, was that, we brought us this research together. We found this really dynamic, really sort of, I say all over the place, but that's sometimes the way it is. Some people are quite certain, and for some people, maybe that decision, does it end at that, when that sort of choice happens, it's hard to know, and everyone's different. It's trying to take into account these many different experiences that people have.
Did you see, like, I don't know if this is what the research covered, but did you see like any correlation between like outcomes in this research, or was it just looking at decision making? So maybe like satisfaction, for example, and things like that.
No, we didn't look at outcomes like that. It was just focused on the experience of decision making. So yeah, I think in qualitative research, we're not always so focused on like outcomes, I guess. It's more sort of about the process of what's going on and, people's like lived experiences. So that's what we focused on. And I think maybe that's why, we approach this conceptualization from that point and that perspective, where, we weren't so concerned with perhaps, as I said, the end point. We're like, what happens in between A and B, like, and like, let's like look into that. Let's explore that. And so, what we found there is that, this is a really, I say, this is an embodied experience essentially. And so, what embodiment, recognizes is, people experience the world with their bodies, basically. And it was trying to really bring that into the decision-making conversation, into the, and what does that mean? If this is an experience that's so, focused on the body and within the body and coming from the body, what does that say about the fact that, we're thinking about, human rights and the importance of, women's and pregnant people's autonomy to make decisions. It's your body, it's your choice. We really tried to ground it in that, to really strengthen the fact that, this is that human rights perspective and coming from it from that angle. So, yeah.
I love the term embodiment. Like, I fell in love with Cassandra when I heard this, because I think I do feel that decision making is about embodiment. You go through so many different things. Like, it's for some people, like the information, it can be equally maybe enlightening, but for some it could be equally fearful. If your options are maybe a particular area that you're not comfortable with, then there is a real kind of visceral effect, and that's going to inform that decision. And then if you was to layer onto that, like the kind of environment that you're in with people who may not be sensitive or understanding towards that, or put pressure on you to make a decision very quickly, then we're kind of really ignoring those like real processes and the impact that has on physiological birth, but just generally in terms of also recovery and postpartum recovery and mental health, which Ori's going to speak about soon. I wonder if you could just elaborate very kind of quickly on this idea of like the beliefs and values, because you mentioned this, and I just want to give you a moment to just explain this a bit more, and then we're going to hear from Ori in a moment.
Yeah, so I guess in terms of, this comes back to, the idea that, so I talked about before, those two main points is that, this is a decision, well, an informed choice, ideally, is a decision that's made after you've had all the relevant information and also reflects your beliefs and values. And so that kind of that's supposed to be, when thinking about just shared decision making, incorporating and making sure a decision reflects someone's beliefs and values, is supposed to be empowering to people, because, this is supposed to be something that comes from them, essentially, within this sort of, good understanding of the benefits and the risks and the outcomes of the care decision that they are making. So, I mean, I guess we could probably go into, preferences, beliefs, and values, and, how you reflect those. And, but I think, what's really important is that, if this is the goal and this is what, we want when people are making decisions, how are you giving space to that within the decision-making conversation? And how are we recognizing, what these beliefs and values are, and how are we responding to them? I say we, but I'm not a clinician, I'm not in these spaces, but how are people responding to, beliefs and values that, might not be in line with theirs and might not be in line with the evidence base? Because, that is really key. If, people are making an informed choice, sometimes that means that if that is what's happening, sometimes it might not be what you think is an informed choice. And so, I think ultimately there's tension there. I think that, when it comes to shared decision making, there are sometimes, in my view, and other people might feel differently, and I'd love to maybe chat about this in the Q&A session, that sometimes there can be a real tension between the concept of shared decision making and the idea of women or person-centered care. Because, we have a healthcare professional, you're doing this in partnership, but who really has ownership and control within this approach? Who has the power within this conversation? Go ahead.
So when you're saying hit now, like shared decision making, so these are two kind of like separate ideas in my mind. So you've got like informed decision making, which is like, it's about the individual, and then you've got this concept of shared decision making, which uses this language partnerships. So I just wanted to make sure that were you kind of differentiate? You wasn't using them interchangeably, was you?
No, I wasn't. I mean, I think, informed choice or informed decision making kind of like underpins. It's like, part of shared decision making, but it's also, it takes into account that, there is a healthcare professional involved in some of these care decisions often. And you're sort of, doing it together, basically. It's supposed to be, bringing the service user like back into the decision-making process, and, really making sure that happens. But, for me, again, with my anthropologist hat on, I'm concerned with, power dynamics and authority and that sort of critical approach to, to anything really. But I start to think, well, who has the power in this conversation? And historically, healthcare professionals have been in positions of power and authority within these discussions, and within care in general. And so, how does that shape shared decision-making discussions? I'm not saying this happens in every single shared, I'm sure that it can definitely happen, but, we should also, recognize that in some cases, there might be other, dynamics that are constraining people's ability to, make a decision on their own terms.
Thank you, Cassandra. And just for those like listening in today, in maternity, we use the term informed decision making, and you may see shared decision making used outside of maternity care. But in maternity, we are using informed decision making. And I think you made a really brilliant point there about like the power within like that kind of use of language of sharing decision. It's like, well, I don't share my body, and I'm not going to share the side effects or the after effects and the kind of lifelong repercussions of maybe decisions as well. So I think that's really important, just in terms of when healthcare professionals are thinking about decisions, it's not theirs to make. And for parents, I know we'll have some parents on here tonight that may be thinking about, okay, I've been told that I need to do something, or there might be certain language that is being used that makes you kind of feel inclined in a particular direction, that it's really important that you know that the decision is on you, because you have to live with the consequences. So this might be something that you need to spend some time thinking about. I know it's not easy to have a conversation with somebody who knows more than you. And that's another thing to think about, healthcare professionals need to think about in that relationship. What does it mean to hold knowledge or expert knowledge and then have a conversation with somebody? And so thinking about like the kind of dynamic that you bring into that conversation is really, really important.
Yeah.
But thank you so much, Cassandra. You've just given so much food for thought, and I hope that we've kind of reframed decision making slightly in this webinar, because I think it's so important that people feel reassured and reaffirmed that all the other things that go into your decision making is important, because it's important to you. So your values, your beliefs, your personal history or the wider history, those are important, and the best person to make the decision is yourself. So thank you. And Ori, would love to hear from you.
Okay. Yeah, so I guess just following on from what Cassandra was talking about, I'm going to be talking more from the, the impact on mental health, and thinking about things from that viewpoint. And I do have some notes, so I'll be looking down from time to time. That's why. So I mean, I guess from my perspective as a psychologist and working with people who've obviously been through the maternity system or are in the process of going through that, I think the thing is, when we think about your birth experience, whether that's through induction or, C-section or whatever it might be, it's just that it's so important, and it has so many, it has, great consequences on your mental health going forward. So it is really important to think about, it's not so much, I mean, in terms of what the research says, it's not so much, necessarily the logistics of the birth, but it's more the quality of the care that you experience and the how of that experience more than anything else. And so, so when we think about birth, and then the fact that some people will go on to develop, will experience their birth as traumatic, and, within that, just to give some statistics around that, about 6% of people will go on to develop a PTSD, which is post-traumatic stress disorder, and then about a third of people will go on to experience birth trauma, which may not necessarily meet the diagnostic threshold of PTSD, but the point is that they feel like the birth has been traumatic. And so I think it's so important to think about the care that's being offered during that time, because when we think about decision making and we think about choice, often some of the risk factors with somebody being more likely to have a traumatic birth is that there's a sense of kind of powerlessness, there's a sense of a lack of control. That's a big factor. Another factor is also the interpersonal interactions that they're having with the people around them, the people that are offering their care. Yes, there's also the factor of, if something goes wrong, or, an emergency happens, and that, somebody might feel there's a real threat to their life, then that can be traumatizing. But so it's important to keep all of those things in mind ultimately, because, birth trauma doesn't kind of just stop at the birth. It can go on and impact your postnatal period, your recovery. It can impact lots of different areas, sort of like your breastfeeding journey, your relationship with your partner if you have one. It can even impact upon, the bonding relationship with your child as well. And it's not to say that if you have a traumatic birth, that's definitely going to happen. Sometimes the postnatal period can kind of be experienced as something that's quite healing if the birth hasn't necessarily been great. But it's just thinking that actually your experience of birth shouldn't just be viewed as an isolated event that happens, that actually it has ramifications, many years down the line. And there are some people who will have had a traumatic birth and, 20 years, 25 years down the line, and feel that they're still carrying that around, around with them. So whether you are induced or whatever your the way your baby comes into the world, it's just being really aware of, I suppose, how you feel it's okay to think about, to sort of have a kind of a critical eye about, well, what the care that I am receiving, is this care what I should be receiving, or is there anything that I would like to be different, and not to just feel that you have to just go along with it because that's just how it is and that's the status quo, because sometimes the status quo isn't what it should be. So that it is all right to kind of have that questioning, mindset a little bit, because sometimes other people won't necessarily, it would be great, if the system allowed for all healthcare professionals to necessarily be able to facilitate that, but you can't guarantee that that's what's going to facilitate it. So it's also about thinking from your own perspective how you can begin to think about those things as well. And that can also be a process of taking ownership of your own, pregnancy journey, or birth experience of the postnatal period as well. But I've said a lot there, so I'll pause for a moment.
No, it's fantastic. So I guess there's a few things in terms of, because I think there's the kind of maternity that maybe myself and you are used to, because we've been around for a few years in this, but there's been a shift in the last 2 years because of COVID. So, a lot of things that people speak about is that they don't have, or they have a kind of limited amount of support because they can't have the birth partner there for the whole time, or for some people, they completely miss having their birth partner there at all because they're not necessarily believe that they're in labor. And so if things progress quickly, the partner can miss the birth. So what are some of the things maybe you've seen during this time, and how should care be shaped? So just kind of from the perspective, speaking to healthcare professionals now, what's some of the things that you've kind of picked up, Ori, and what you think should be happening?
Yeah, I mean, in terms of the people that I've worked with over the last, I guess, the duration of the pandemic is definitely that notion of not really feeling like there's enough support, and even in very kind of special circumstances as to why you might make the exception that somebody can have their birth partner around for longer than what the policy dictates, that sometimes it feels like responses have been very kind of rigid to that. That's not to say that that's everybody's experience, but just from the people that I've spoken to, that's been a bit of a battle. And then it's just that then adds another layer of distress to what might already be quite a distressing situation, because so for example, if somebody their pregnancies had been really difficult, or maybe they had something like hyperemesis, so actually then to get to the point, I think it's really important to consider the journey of that person has been on to get to the point where they're about to give birth imminently. And I think also just that idea of because support is so important. The research tells us that actually support is a big protective factor for your mental health. And it's when people, that's not the only reason, but one significant reason is that when people don't feel supported, their mental health is more likely to suffer. They're more likely to develop perinatal mental health difficulties, down the line as a result of that. So I think, I hope this isn't idealistic, but I think, it's important to think about, well, the impact of the fact that that person, or the people who have been giving birth in this period, are not necessarily having as much support as ordinarily that they would have done, and that ideally space would be made for that, even when they are making choices about how they want to give birth, or what the intervention options might be. And also just thinking about that as well is if say you're dealing with somebody who's maybe suffers from anxiety or depression during their pregnancy, it's not to say that somebody who's experienced depression or anxiety can't make their own decisions or can't take ownership. Of course they can, and many people do, but sometimes your ability to do that can be compromised. And so sometimes you might end up sort of agreeing to something that you wouldn't necessarily have agreed to if your mental health was ideally where you would have liked it to be. And so, to also take that into consideration as well, and give space for the person's experience. So I think, also in terms of thinking about how care should be shaped, I think very much with a trauma-informed lens. And, you know, they're the 6 principles of trauma-informed practice, which are safety, trustworthiness and transparency, peer support, collaboration, empowerment of voice and choice, and then being aware of cultural, historical, and gender issues. So, I mean, that obviously that can be unpacked and can be interpreted in lots of different ways. But I think for me, the way I understand it is being aware of the person in front of you and what their trauma history might be. And it's not that you need to know that, you know, the ins and outs or all the details about that, but being able to ask those questions. Because the thing is that sometimes birth can be traumatizing, not necessarily because of what's happening in itself, but because of the kind of emotional significance that experience has for that person. And then we would, you know, Cassandra was talking about power dynamics. And so for some people that can be really triggering. Say if somebody's experienced past emotional abuse, physical abuse, sexual abuse, or, you know, in that way, whether in childhood or later on in life, actually being in a position where you feel like somebody has more of the power can kind of end up in, you can end up in a position where you feel very silenced. And that might just be taken for granted as, oh, that, you know, that person maybe doesn't really have much to say, or they're okay with what's being suggested. And sometimes that's the case, but I suppose what I'm saying is that sometimes that's not the case. So it's just about, I guess, you know, having that level of emotional attunement and space to kind of ask, but ask again, and check, but, you know, double check, and kind of even sometimes I think it's fine to be explicit and say, you know, if there's anything that you're concerned about or anything you disagree with, I welcome you kind of saying that, because it's important to have that dialogue that's open. And yeah.
One of the things that I'm thinking about as you're speaking is the importance of relationship building, because I'm just thinking that, you know, there's some people who maybe are aware of having PTSD, but there's some who would never get a diagnosis. For example, we know that Black women are less likely to be diagnosed with it, but they're at a higher risk of actually having it. And so they might not be aware that they even have it. But then there's an issue of whether they want to discuss it if they do know, because they might not feel safe. But also, could pregnancy itself be a trigger or a kind of risk factor to somebody's mental health? Would that be the right framing? So basically the actual pregnancy itself be something that kind of like triggers not so much PTSD, but perhaps like other kind of mental health disorders.
Yeah, I mean, it can be, but I mean, okay, how I'll explain it is that, say, for example, if somebody's experienced, you know, previous pregnancy trauma or you know, a loss previous to that, it can be a trigger, say, for example, for that person to develop quite high anxiety, which is completely understandable, and it depends on how much that impacts upon your functioning. But for other people, it might be, say, that actually, say if it's their first child or something, but actually their own experience of being parented, their own experience of being mothered was really, really difficult, or was really, really negative, and they didn't, you know, they don't feel like they had a very good blueprint or model to draw on. And so sometimes the process of then becoming pregnant and then knowing that you're going to become a parent, that can be really triggering. So I would say it's not necessarily the pregnancy itself, but it's more what the pregnancy represents or means to that person. And so that person might really struggle and, you know, become really anxious about their capabilities of being able to be a good parent, and that kind of thing. And I think, you know, also, if you've had mental health difficulties before becoming pregnant, you're at a higher risk of developing mental health difficulties during that period, but it's not like a guaranteed sure thing that you definitely will, but it's something to be mindful of. And if your team around you should hopefully have asked you those questions about your past mental health, so that's something that can be taken into consideration and planned for as well, especially depending on how severe the mental health difficulties were. So for somebody who had psychosis, for example, and, you know, just to give a brief explanation, I mean, it's a lot more complex and nuanced than this, but, you know, maybe somebody who's experienced sort of like hallucinations or delusions, or kind of their perception of reality is just very different to everybody else around them, is one way to understand psychosis. So that's quite serious, and it's considered, you know, sort of like a medical emergency that happens during the birth sort of period. So then that would definitely require a lot of planning around support, thinking about medication, that sort of thing. So yeah, I think it's more about what it represents, and I think that's another thing that people can kind of think about themselves if they feel able to, or maybe talk to a friend about, or, you know, even if you wanted to see a counselor or a therapist or whoever's in your support network, just to think through actually what does being pregnant mean to me? Like, what does it throw up for me? I mean, it might throw up really positive things, but it might also throw up things that feel quite negative. But I think it can be hard to have that. There can be a bit of ambivalence, because you don't want to think it throws up anything negative, but sometimes it does, and it's not really about necessarily the pregnancy, but it's just about, yeah, the significance that it has for you. So I think it's really good to just be aware of your own kind of signs and symptoms of maybe when your own mental health is starting to deteriorate, or just becoming aware of what you know tends to compromise your mental health and makes you a bit more vulnerable, so that you can put plans in place, you can identify resources or people who can support you if you were to need it at a later date.
So you've mentioned PTSD, you've mentioned psychosis. Are there other mental health conditions or disorders that we should be aware of, or expecting parents need to be aware of as well? Because I didn't really know about this prior to having children. I only actually found out about them once I had a child, and I was like asked a few questions about how I was feeling, and I was like, why are they asking me these questions for? So
yeah.
What other conditions do people need to be aware of?
Yeah, so I mean, the depression, anxiety, those are the most common ones. That's what people tend to experience. There's also tocophobia, which is like a fear of childbirth. And sometimes that's got nothing to do with having had a previous traumatic birth, but sometimes somebody can develop a fear of giving birth again, understandably, if their birth process was really traumatic. As well, and even within anxiety, there's different sort of I guess anxiety disorders or anxiety problems. So it might be that somebody has more social anxiety around kind of being a mum and sort of worrying about what other people might think, and, you know, being in social situations with other people, that can create a lot of anxiety. Or you can, sometimes people can have something called generalized anxiety disorder, which is more sort of a general just worrying about lots and lots of different things. So it's not really necessarily about anything specific. It might be about this one week, but then that might be resolved, but then the anxiety kind of pops up again and it's about something else. So it kind of latches onto lots and lots of different things. So those are probably the main ones. And then there's also obviously OCD as well. So that's obsessive compulsive disorder, and often that's sort of in term within the perinatal sort of period, it's sort of in terms of intrusive thoughts, and sometimes people might have thoughts of sort of like harming their baby or doing something negative to their baby, or their baby sort of the safety of their baby being compromised, you know, and sometimes that can be really, really distressing. And the thing is that they don't want to have these thoughts, and they're getting distressed because they're having these thoughts. And so they might end up, you know, engaging in sort of obsessional thinking, and then engaging in sort of behavioral rituals to manage the obsessions as a way to manage their anxiety as well. So that's something that's something else that people can develop. So anxiety, depression, psychosis, PTSD, those are I think the main ones that I would say. But I also want to say that it's not just about thinking about mental health conditions as, you know, kind of diagnostically, as, you know, might be referred to by your GP or your health visitor, but it's also your mental health can suffer, say, if you're having breastfeeding difficulties as well, or actually sometimes people really struggle with their sense of self and identity when they become parents, and that can cause a lot of distress as well, and their mental health can suffer as a result. So I think it's important not to get caught up on, it's good to know about these different conditions, but also not to think that, well, but it doesn't seem like that, then that means I don't need to seek out. Because it's like, if you're feeling like things are not okay, it's okay to seek help. Like, you don't need to meet a threshold to get the support, because the earlier you do it, the better ultimately.
So just one other thing that I wondered if you could elaborate on is baby blues. So we've got the kind of bigger kind of conditions that are referred to, but what about baby blues? Like, what does baby blues look like, and what kind of support is there for that as well?
Yeah, so baby blues. I'll speak of it from a psychologist point of view. I'm not a medical doctor, but so I know that baby blues is more around kind of like the hormonal changes that are happening post birth and kind of recalibrating themselves, and just that sort of like first 10 days, 2 weeks is completely normal to feel tearful, down, low, not quite yourself. And that's completely normal. It's not pleasant, but it's normal, and it's expected if it happens. But I think the important thing is to notice that if that's kind of persisting, so if it's dragging on for 3 weeks, 4 weeks, I mean 3 4 weeks, it might be that you are actually depressed and that you need to speak to your GP or speak to your health visitor or speak to your midwife at that point, and then you can be referred to talking therapy services. Obviously there's a long waiting list for that, normally several months, unfortunately, but obviously if you have the means to do so, you can also seek private therapy as well, if that's something that you wanted to do. And it's not that you need to commit to 10 weeks or 3 months of therapy. It might just be a couple of sessions is all you need, to just kind of make sense of things as well. So I think the important thing is that if it's persisting, if it's really seriously impacting upon your functioning, and I know it can be hard to differentiate because obviously you're sleep deprived.
Yeah.
Lots has happened, lots of changes have happened to your body and all of these things. So you're not going to feel like really robust necessarily. So it can be quite hard to differentiate. Is it just I'm sleep deprived and all of that, or is it something more? So that's why I think it's so important to know yourself and to know when, because there are times when we're under stress, but we feel we can cope with it. We feel like we're okay. It is stressful. It is taking a toll on our bodies, but we still feel like we're okay. And then there's times when we're under stress where we feel this is stressful, but it's kind of penetrating a lot deeper. And I would say if that's the sort of feeling that you're having, then it's probably not just because you're sleep deprived or you're having to deal with all of these changes. But it can be hard to differentiate. But either way, if you're not feeling good, you're not feeling good, and it's completely fine to seek support. I would encourage it, and also identify safe people as well you can talk to about it. Maybe it's a first step to thinking maybe you go to your GP, or if you're feeling sort of nervous about having that conversation.
So in terms of, I don't know if you know this because I know you said you're not a medical professional, so forgive me, not your area, but in terms of like planning for all of these, I feel like they all require like planning and preparation. We often talk about creating a birth plan, and we think about pain relief and how we want to give birth, music and all these other things. What about mental health? Like, what can people do to actually prepare for their kind of mental health around the end of pregnancy, or just generally pregnancy, labor and the postpartum? Do you have any kind of like a bit of a toolkit that you maybe share with people?
Yeah, I can give some ideas. Obviously different things will to work for different people, and pick and choose what you like is just kind of general. But I think the first thing I would say is just, like I said, identify your kind of what your vulnerability factors are, is the term we would use with a psychology spaces. But that's kind of like, what is it? What are your triggers? Like what? And when I say triggers, what are the things that if they happen or they don't happen, or you experience or encounter, really affects you, really affects your mental health, really affects your sense of self, I suppose, or weakens that? What are those things? And being able to identify those, identify what your needs are as well. It'll be different for different people. So for some people it might be that actually they want lots of people around them, and they need to feel that tangible support. But for other people, actually they want people around, but they need a lot of their space. They need their space. Also thinking a little bit about your boundaries. What are your boundaries in terms of people visiting, or dealing with in-laws, or you have them, that sort of thing. So I would say identify what your needs are, and that's just in terms of relationships, in terms of your own personal needs of like what feeds you, what nourishes you, that sort of thing. Also what your needs are in terms of your environment, because that you were talking about that idea of embodiment, and your body, it's like your physical space makes a difference as well. Obviously the normal things like nutrition, or gentle exercise obviously initially, and routine is really important. I know obviously not solely the sleep routine, but even if you can come up with some sort of structure to your day, those things are really important. And just thinking a little bit about the things that you can do that are compassionate to yourself. So it can be just something small, and it can be something behaviorally that you do. It's not that you need to necessarily feel lots of compassion or think lots of compassionate thoughts to yourself, but it's an act. It's an act, sort of like to invest in yourself, ultimately. And I think if you have had previous mental health difficulties, definitely, because sometimes people will say that to their maternity team, other times they won't. So, but I would encourage, if you feel safe enough to talk about that, and also thinking about what's helped in the past when your mental health has suffered, or when you found things difficult, and, seeing if you can kind of identify what those factors were and how you can kind of reintroduce them again, now as well. I think also identifying resources. So it might be identifying breastfeeding support, lactation consultant, infant sleep consultant, just what else, maybe a couple of people's profiles, or who, if you think you can afford to pay for therapy, that if you did need it, you could contact them. Also be aware of the the different charities that support parents as well. So I would say just kind of like build that up, know what the numbers are, know what they are. So it's not when you're in distress or in crisis, then you're then having to think, what am I going to do about this, or problem solve? Because actually when we're like flooded emotionally, our ability to think is really compromised. So just thinking about that as well. And just, I would say, be very much guided by your needs, and be very much guided by your values as well. Because it can be quite a tumultuous time, and you can feel like your sort of sense of self is being reconfigured and you're not quite sure what's going on. But that can be something you can keep coming back to, that makes you feel like you can come back home to yourself, I suppose, as well. So those are some general tips, but things to kind of think about as well.
I think one last question for you, and then we're going to go to the Q&A in the chat section, is I want to think about like faith, like women from like faith backgrounds. I've like seen before, like right across different faith groups, for example, like the pressure of being like the perfect mom, and juggling and balancing, and kind of reliance on like prayer, or kind of like those tools, which we know they can be useful. But do you have kind of any like messages of like encouragement, support for women who are just maybe going through it now, and they feel like, okay, they're failing, and but actually, what do they kind of need to think about, and how can they maybe build their support? Do you have any kind of tips for that as well?
Yeah, I would say, I think I can understand what you're saying. I'm a person of faith as well. I'm a Christian by background, so I understand. From that particular faith group, I can understand the type of narratives that go on, and very much about prayer, and take things to God and all. And I think that's completely valid. And again, that's a spiritual need, isn't it? Obviously, your faith is more overarching than just one section of your life, but there's that. But there's still other resources out there. And so why is it that, when I would say, just kind of gently challenge yourself that just because it's mental health related, why does that mean that you can only pray about it, that you can't necessarily do anything else? And I would also say that just because, I think something I read a while ago was just like, just because it's natural doesn't mean it's easy. And there's this idea, because it happens naturally, and we know our bodies are made to do this, that it should not be smooth sailing. But sometimes people are really shocked by how difficult that they find it. But I think what I really want to get across is that normalizing that it can be really difficult. It can be really difficult, and that it's a process and it's a journey, and like you're going through different seasons, and you're in a particular season, and 5 years down the line you'll be in another one. And also to really normalize that ambivalence as well, because even within faith communities, it can be I suppose, frowned upon if you were to voice the fact that actually you weren't really enjoying it, or actually you're finding this really annoying, or you're finding something really boring, or you might have things like, oh, you know, kind of not regret, but kind of thinking a wish to kind of return to your former life. And I, you know, I know it might be easy for me to say because I work in this space and all of that, but just genuinely that's all normal. It's normal to feel ambivalent. It's normal to feel like you're finding it hard. Like it's natural. Lots of people have been doing it across time, but it's still a big undertaking. You've carried a baby, you've birthed a baby. You know, you're then going to be raising. It's not to underestimate the gravity of, not to scare anyone, but also not to underestimate the gravity of it. Just because it happens all the time, it's such an important role, and it's such an important time, and to give yourself the time to figure it out and navigate it, and not to rush, and to be really kind to yourself as well. And also to remember that sometimes people will say things like, oh, well, you shouldn't think like that, or just be happy that you have got a healthy baby and God gave you a baby, you know, all of those things. And it's like, at the end of the day, we have to remember that people say things that reflects their own worldview. It's not the objective truth. That's what they think. And that might have been something that they told themselves to manage when it happened to them. But actually, you don't know that maybe they had the same types of thoughts as you. But it's because, I guess, there's a culture of silence about speaking out about those kinds of things. But it's like, people are only ever telling you part of the story, not the complete story. So don't transpose one thing that they've said to apply it to your whole experience and life. And finally, that your feelings, whatever they are, your experience is completely valid. Completely valid. This isn't a space for it isn't a space for judgment. This should be a place for non-judgment and just compassion, I think.
Yeah. And I think, because I really struggle, like I'm all from Christian background as well, and I at times felt like there was tensions between the kind of blessing of motherhood and then like actually maintaining a relationship with God and church attendance. And I was like, you know what, like now I'm like 7 years in, okay, so they're not babies, they're children, but I see myself as postpartum still, and I'm just like, I'm tired, like I am not getting dressed and I'm not getting up, like I need rest. So I think it's also about, like what you said, like feeling valid, accepting like where you're at, and just being okay with that. And you know what, it's personal to you, and you don't have to kind of prove yourself. You know, this whole period we have to take care of ourselves and give ourselves time. And for some people that's like, they're okay a year. For some people they're okay 2 years. Like me, I'm here, everybody, I'm putting it on the record, it was 7 years later and I'm still taking my time. And you know, each stage of childhood and parenting, and because we've spoken a lot about birth, but the kind of parenting journey is just full of many transitions, full of milestones and moments. So even if we're talking here about the post kind of natal period, it's really important for us to remember to be gentle, you know, as our children are even going into adulthood, because it's hard and they're human, they're going through their own things. Everything's new. Every stage, every day is new. So also for those that are kind of going through that kind of spiritual challenge, or you know, a part of faith groups and just thinking, oh, I can't get it together, I can't hold it together. You know, this is as much for you as for everybody as well. So thank you both so much for those insights today. I really hope for our attendees it's been really, really helpful and insightful. So we'll go to our questions. And the first question is from Anna, and it says, how do the opinions, both personal and professional, of medical professionals influence women's decision making? So how do the opinions of medical professionals influence women's decision making? Oh no, sorry, that's not the first question, but we'll answer that one, it's fine. Cassandra, I think this is geared towards you. What's your thoughts on this? How do the opinions of medical professionals influence women's decision making?
So, I mean, Of course, well, I mean, there are quite a lot of opinions that, professionals might have, but, and sometimes, what I think is always really important to remember is that healthcare professionals are coming from a place of, using evidence-based practice. And so I don't want to generalize too much about them or speak badly of any healthcare professionals, because I really respect everything that they do. But obviously, some people interpret the evidence-based differently and see things differently. I mean, this is something we've experienced quite recently with induction of labor, with the new nice guidance consultation. There was a very big, large and public discussion about, how some of those recommendations, perhaps in some people's view, did not have sufficient evidence. So people will, I think it's always important to, remember sort of, you were talking, Ori, about, the different worldviews. And, obviously, when a healthcare professional is coming from that place, they are believing that, based on their knowledge and their understanding of the evidence, they believe that, this is perhaps the best option. Or the best, and this is, sort of how they are approaching the situation. And so obviously different healthcare professionals will take different approaches. Obstetricians, see a certain part of care, midwives see a different part of care, and that is completely fine. I mean, they both have benefits and they're great working together and in partnership too as well. And so I think that is one of the ways where, you might come up against, differing opinions on something and how it can impact care or influence decision-making, because the way that the decision or the information is presented is really framed in a way that will reflect that opinion or that interpretation of the evidence. So, when we're talking about induction of labor, this is about mainly thinking about, how are the risks of induction of labor and how are the risks of, continuing pregnancy perhaps beyond 42 weeks is being framed within those discussions, and that can really influence people's decisions. And, I think that it's always important, or we've talked about before, is that whether you decide to have an induction or not to have an induction, or whether you decide to have a home birth or a hospital birth, all these decisions, these are very valid decisions. And so, that is really always very important to remember, but that's not to say that they can't be influenced within those discussions. I hope that answers your question, Anna, but yeah, it's a great one. Thank you.
I think also one of the things that I think about, Anna, as well, is like the culture as well. So if a particular area has like a culture where they maybe lean towards certain types of births or interventions, and that can also influence the way that decision-making conversations are had. I don't think it's done here in a wide scale, or maybe there was some work being done on it, but I know in the States, for example, they have tools where women can, and birthing people can check the, for example, like cesarean rates of a particular hospital or a state. And so they will make their decisions based on, I guess, what type of birth that they want. So that's kind of something that your questions made me think about as well, Anna. So the very first question was, have you found that women and birthing people find that they have real choice when faced with decision-making in maternity care? So it'd be interesting how you define real choice, Cassandra.
I guess, yeah, it's a hard one. I mean, I know that in my PhD, I did argue that it might perhaps be very difficult, if not impossible, to make a truly informed choice within the sort of frameworks of choice. And I know myself and I know other researchers have also been talking about the same thing. Yeah, I mean, I guess, it's to what extent you view, if we're thinking you sort of make a choice within a framework, and it's framed by the evidence and the knowledge and the sort of, the like values and sort of, sociocultural understandings of, pregnancy and birth. If we're sort of talking about that's sort of that framing, can people make a real choice within that frame? I think that's a that's a big question. I mean, I'm leaning towards sometimes perhaps at the moment, not a lot of people are able to, in my opinion. But of course, there are people who do, and do feel that they have had a real choice and they have made an informed choice. They were given that opportunity. And I think, it's really important to figure out like what happened in their care, like what happened in their conversations, like why do they feel this way? And, what was going on within their sort of, pregnancy and birth experiences that sort of led them to, have this positive experience. And, I think it's really good, if we talk about more of those, positive experiences of decision making and choice within maternity care. And, I think totally lost my train of thought, but yes, I don't want to sound so negative about it, but, it is a really serious question because, we are really focused on, as I said before, with the policy, having this informed choice. And I think, it's important to step back and say like, whoa, can we even are people even able to do this? Like, are they even able to have this informed choice, within the sort of spaces that we're creating for decision making? So I hope that answers the question.
Yeah, do you know what? This is a really, probably not the best example, but it's almost like, as a parent, I kind of do things like this to my children. Like if I want them to take a particular thing, I'm going to give them very restricted options. If I want my children to eat vegetables or something healthy, I'm not going to, say to them, oh, do you want a snack? And then they can just choose. I'm going to say, okay, do you want a carrot, just chopped carrots or chopped cucumbers, right? And they know that there's perhaps crisps in the back. And so they're thinking, well, why can't I have this? So I think that's kind of one of the things that I think about is that who decides what the kind of selection of choice is and when they kind of fit for, I guess, the offering. And I guess I'm thinking that's maybe what Anna was also thinking about as well, what real choice, who decides, for example, who gets to go to the birth center, who gets to decide who has a home birth, etc. Yeah, it's definitely something that healthcare professionals think about when they're offering choice as well.
Yeah.
Ori, sorry, Cassandra, was she going to say something?
Oh, no, I was just agreeing with you.
Ori, sometimes you hear healthcare professionals influence decision-making by presenting the harshest health outcome, for example, infant loss. In your experience, how do healthcare professionals take into account how birth trauma and coercion can impact people long-term?
So I guess I can talk mostly from my experience of professionals through the clients that I see, I suppose, and the kind of things that they may say or tell me. And I think there's obviously people have a mix of experiences ultimately, but it seems, my perception is, it seems that it's not necessarily taken into consideration long term, as in I think anyone can obviously think, if somebody has a traumatic birth or they feel coerced, that's obviously going to impact on them. But I don't know how much thinking there is around 2 years down the line, 5 years down the line, that sort of thing. And I know that there's a lot more resources for healthcare professionals to engage in, the Make Birth Better campaign as well. And they do a lot of training about birth trauma awareness, which I would encourage any maternity professional to attend. To be honest, so that's probably what I say. I don't think it's really long term, but I think it's so important to think about long term, think about the past, but also think about the present, but also think about the future at the end of the day, because these people who might end up feeling coerced or feeling traumatized, I mean, what's the trajectory? They're going to end up in services later on down the line because of things that maybe could have been preventable, or even if they weren't preventable, could have been addressed properly at the time so it doesn't linger. Because you do hear about people who maybe had a traumatic birth, maybe didn't necessarily see it that way, but that's what the experience was, and then developed postnatal depression, and then 3 years, 4 years, 5 years, they're still really depressed. And is there an understanding of the origin of that, and where that came from? So I think it's so important, because also with coercion as well, is that, again, it's about being really aware of like re-traumatizing dynamics that can happen within healthcare systems. Obviously it doesn't happen all the time, but it can happen. And and that's very much around language, how you speak to someone, how you address someone. And I think sometimes people can experience healthcare systems or certain professionals, obviously not all, it's a bit paternalistic. Then there's almost this kind of like parent-child type dynamic that plays out. And I think very much it's about, even though yes, you're the expert in your knowledge, but they're the expert of their own personal experience, they're the expert of their body. So you're both experts in different things, and you're bringing your two minds together to think about what would be best. So I think it's really important to try and kind of facilitate an adult to adult interaction, but I think often that doesn't happen. And sometimes that's easier for some people to do than others. Some people are very vocal, some people are very assertive, but not everybody is. Some people can struggle with that. And often if you have experienced interpersonal trauma, then at the hands of somebody else, then when you're in a power dynamic filled situation, it can be very easy to revert back to being a child or childlike or compliant in your response, even though that's not even what you want to do or to say. So I think I wish there was more of a consideration long term, but I think that there's a lot more awareness of it now. But I think, like I said, I think everybody should be birth trauma and trauma informed trained, to be honest. I don't even think it should be an optional thing.
I agree with you. And sometimes like that kind of, like you said, that revert to that kind of childlike mode is a survival mechanism. It's like, I just need to get through this pregnancy. I can't have any more fights. I can't have any more conflict or tension. It's wearing me down, or it's, they're worried about the impact on the baby of the stress. So yeah, definitely, I hear you on that. And last question again for you, Ori, is how clued up are healthcare professionals at picking up on perinatal mental health? Is it only the most severe cases and people with moderate mental health issues find support? Sorry, is it only the most severe cases? I don't know if that's all people with moderate and mental health issues find support. So I guess like how good are they at picking these things up, and how do people find support?
Yeah, I think they're a lot better now. Also just thinking about things like perinatal mental health community teams being developed, and mother and baby units, and I know they've commissioned like maternal mental health services now as well. So I think they're a lot better, and obviously those types of services have to have quite a strong link with maternity wards or maternity hospitals and that kind of thing, because often people will kind of go through that, will transition into maybe a community team once they've been discharged from hospital. And I think it's really good that a lot of hospitals now will have specialist mental health midwives as well. So people who, maybe have already had previous mental health difficulties, maybe allocated to that midwife, or they pick up that that person's struggling with their mental health, and then those resources. So I think it's a lot better than it used to be, but I do think, yes, it does tend to be the more severe, because the more severe is obviously a lot more apparent to the naked eye, I suppose. So you are going to pick up on things like psychosis, because it presents itself in it's very divergent from the norm, if that makes sense. So you're going to notice it. So I think with the severe end, yes, but I think what gets missed is more the mild to borderline moderate, because that you can kind of think, well, the person's functioning, they're okay, they seem all right. Oh, it's normal to feel like this, it's normal to feel like that. And yes, it is, but just because it's normal doesn't mean that you shouldn't then have any support. It's not like it's normal, therefore you'll be able to get on with it, sort of thing, which sometimes can happen. But I know there's a lot of training for GPs nowadays, because obviously they're the front line, aren't they, after you've been discharged and you're having your 6-week check. But having said all of that, I do think it could be a lot better as well. I think, again, I know this might be really idealistic and utopian, but I think all maternity professionals or people who work in that space should have perinatal mental health training. I think they should. It doesn't have to be, you know, even if it's basic, but I don't think it should be an optional thing that's rolled out. And I know a lot of places do roll it out, but sometimes it is an option as to whether you're going to do it or not. But I think I just think there's so many people fall through the gaps, or so many people will go to the GP, I'm not feeling too good, and it kind of gets dismissed and shut down, and it's not, they don't, you know, they're not necessarily trained to really be able to assess comprehensively when this person says I'm not feeling too good, what that really means. And I think, you know, it's important also to unpick your assumption as to when people say things like that, what you might think it means, oh yeah, I'm not too good, but I'm all right. Whereas the other person's like, I'm not too good, but actually I'm literally falling apart inside. And where's the space for that those unspoken words to be heard? So I think we're making progress, but more could be done, definitely.
Yeah, and I remember my experience with my GP, and I just kind of think to myself, like, do they have space? Like, can they hold space? Like, do GPs hold space? Well, I'm not saying that all of them don't, but you know, I think that that's really like important. It's sometimes just not some people's gift. You're like, you know, somebody who's like on the ball, they're like, okay, I'm picking something up here, and the compassion just shines through. And so, like, I'm kind of like you, I'm really utopia when it comes to maternity services right across all areas. I'm like, we need this, we need this, we need this. And like, in an ideal world, I really think that like a strong mental health framework needs to be really part of the planning of maternity services from the whole kind of first 2 years. I know there was a effort with, for example, in Lincolnshire, they had this BBCS project with NCT, where they had these birth and beyond community peer supporters, and it was a good idea. I think it was really successful in Peterborough for a time, but that's really important because it was like peer supporters. It was people who had the lived experience, people who had the time, and it was often that you was encouraged to talk to parents and speak to parents in places and environments that were comfortable. When I go to the GP, I'm not the most comfortable person. Like, it's not the most comfortable place. There's a lot of sick people there, and that would just like put my anxiety up in that waiting room. It doesn't run on time for the most part. And then like, it's just like, okay, what are you here for today? And usually that kind of mental health conversation is like, this is going wrong, this is going wrong, the baby's not fine, my nipples are bleeding, you know, and there's just so much that you need to feel that you can unfold. And if they ask you that question, like, how are you feeling? It's just like, I'm okay, I'm all right, it's a bit hard. And actually underneath, there's a lot going on. And there's like a meme that people have made where there's like a woman that's frazzled and she says like, I'm fine, and then you see this kind of like speech bubbles where it's like all of this stuff is going on. So I think that like the mental health support, like we really need to be able to invest in it so that people have time to spend with expectant parents.
It's such an issue of time though, isn't it? Because some people really do want to be able to offer that, but they're so stretched themselves and they can't. Obviously some people, it's got nothing to do with time, they're just not very personable, I suppose. But I feel like you know, maybe this is naive, but I feel like you've got to be though. You've got to be personable when you're you know, it's not just about your medical knowledge or whatever it might be, but it's like it's the person in front of you, isn't it, at the end of the day? So yeah, I mean, I hope that things will progress a lot further. I really hope so. And I think the other thing I'd say is that also to move away from the focus only being on postnatal depression as well, because you know, even some of the outcome measures that are used to assess if somebody's struggling with their mental health, like the Edinburgh postnatal depression scale, it's like, yeah, but that doesn't pick up tocophobia. That doesn't pick up birth trauma necessarily. And often people who've actually have the core issue is birth trauma, but that can develop into depression, but they'll think it's depression, but actually it's birth trauma. So I feel like it needs to be a lot more, the assessments and things need to be a lot more nuanced and a lot more varied. Because what about, you know, different types of anxiety disorders, like I mentioned earlier, OCD and all of these things, they don't get picked up, and it's like depression is the headline. And I understand that because it's very common, but it's like there are lots of different types of issues that people, because then people think, oh, well, it doesn't quite look like that. So what is it?
Yeah.
If I don't have a name for it, maybe it doesn't really exist, kind of thing.
Yeah.
So.
Especially like anxiety, for example, because it has a kind of quite physical manifestation. Like I went through a stage where like I felt like I couldn't breathe all the time. This is when I had my second son, and it was like they could never find anything wrong with me. But it was one, exhaustion and anxiety. But it was only because I was just trying to figure out what was going on that I kind of realized what was going on for myself. And so it's a real kind of thing, like what you're saying, like we need to make sure that we're thinking about other ways, because that's quite, I can see how that could for someone else get out of hand. You know, for me, I was like, when I realized what it was, it helped me to find tools to cope and deal with it. So that's why like now I can say no, I can put boundaries in to like not be the kind of perfect mom, perfect friend, perfect wife, you know, because it's like, well, actually, like all of that pressure for me doesn't make me feel good, doesn't make me feel well. I can't sleep because it's running on my mind, and I'm already juggling 3 children. So for me, it's like we need to invest in mental health services. Probably got great resilience, but there's a lot of people that don't really always have that and can't bounce back. So we definitely need to invest in it if we care about women. So I don't think there's any more questions, and it's been amazing talking to you both and hearing you speak, and definitely hearing like these different perspectives. So thank you both, and also thank you for all the attendees that joined us today and stayed with us. So thank you all, and you're free to go.
Yeah, thank you. It's good to be here. It's a lovely conversation.
Yeah, thank you so much.